Oncology NSABP B-35 study, a clinical trial of anastrozole versus tamoxifen in postmenopausal patients with DCIS undergoing lumpectomy plus radiotherapy. Very similar trial design.
Thank you very much for selecting this for the press program, and my colleagues from the NSABP, Dr. Larry Wickerham and Dr. Tom Julian, are in the audience, as well as I sponsor the NCI, Werda McCaskill-Stevens. So thank you for being here. So these are our disclosures from the many authors here. I have no personal disclosures. So the NSABP B-35 schema is shown here, and this was a study in postmenopausal patients with hormone receptor positive DCIS that was treated with lumpectomy with plan for radiotherapy. So all of these women had lumpectomy and radiation therapy, and this was a double-blind placebo-controlled trial. Women got 2 pills. They got an active anastrozole pill and a placebo tamoxifen, or an active tamoxifen and a placebo anastrozole, and they took this medication for 5 years, and we followed them up. And this was the primary outcome for our trial. It's a composite outcome, as you can see here. It was time to any breast cancer event, such as a local recurrence, a regional recurrence, distant disease, or a breast second primary that could be either invasive or DCIS. So many, many things combined together to look at a sample that's powered to detect this difference. So these were the results that were presented last year at ASCO, and as you can see, there is a 27% reduction in hazard of recurrence in this composite complex endpoint, but just pointing out the anastrozole arm here out at 10 years had a 93.5% event-free survival, and for the tamoxifen group it was 89.2. So this shows you the extraordinarily high quality long-term disease-free survival for these women. Now, we stratified our trial by women being less than 60 or over 60. These were all, again, postmenopausal women, but we actually had specific a priori hypotheses specifically related to the quality of life study that the toxicities of these 2 drugs might differ according to how close you were to having gone through menopause. And if you look at this here, there's no significant benefit when you compare tamoxifen to anastrozole on the right in the women over age 60, so it's dealer's choice there, they're equivalent. But if you look at the left, the benefit is primarily in women who were less than 60, and there's about a 5 or 6% difference there between the 2 curves. That is statistically significant, and there was a statistically significant interaction between age. So the benefit in this trial that we saw clinically was really only in the younger women. So for the quality of life study that was embedded in this trial, and it was a secondary outcome among others, our primary hypothesis was that there would be no difference between quality of life between the 2 treatments, and that they would be equally well tolerated. We had a hypothesis that anastrozole might have a higher rate of hot flashes, particularly in the women less than 60 years of age. At that time, we had very little data to go on about what the quality of life impact would be. The results of the ATAC trial in invasive breast cancer didn't have its quality of life results come out until several years later, so we had made this hypothesis. Our secondary aims for the quality of life trial, again based on some early data from ATAC, were that there would be greater vaginal dryness and pain with intercourse with anastrozole, and poorer sexual functioning with the anastrozole group compared to tamoxifen. We used a battery of instruments that really built on our prior breast cancer prevention trials, the BCPT P1 trial and the P2 STAR trial, where we had learned a lot about the biology of tamoxifen, and in the case of STAR, tamoxifen and raloxifene. These are validated scales that we had a lot of information on. And we used an intention to treat analysis, and we compared the 2 arms using mixed models for repeated measures with adjustment for baseline scores, time point, and age category. And again, looked in this case through 60 months. The questionnaires were administered every 6 months from baseline on. We also have data in the year afterwards, but we have not analyzed that as yet. So this is the consort diagram and schema for the trial. You can see there were over 3,100 patients randomized to the trial. We had 1,223 patients in the quality of life sub-study. We basically continuously accrued until we reached what had been our target of 1,150 patients, which was an adequate sample size for the trial. We over-accrued a bit, but we needed a total of 500 patients in each arm who would be evaluable to be able to answer this in a statistically well-powered design. I'm just showing a few of the patient characteristics here. You can see more of the women were over age 60 years, but it's pretty closely divided. And we had about 12% non-white women who participated in this trial. The medical characteristics were also equally divided, and this sample represents the population that was in the full trial, so it's not a selected group. So here are the first results. You can see on the left with the SF-12 physical component scale, there's absolutely no difference between the two treatment groups over the 5 years of the study, and on the right, the mental component scale. The mean or median for the population in the US is 50. The physical function gets worse as we get older, so there's a little bit of a decrement there, but what you see is there's no change in physical functioning or mental functioning as women took either of these two drugs. Here, what you can see is the frequency with which women reported hot flashes, at least a little bit bothersome, and I'm going to show you the severity scores in more detail. When we originally looked at the design of the trial, we were interested in both frequency and severity, and to make our data a bit more comparable to what's reported in terms of the toxicity from the IBIS trial. If you look on the left, and again, the yellow is the tamoxifen patients, the aqua are the anastrozole patients, and if we look at the first column for hot flashes in women less than 60, you can see they have a higher rate. It's in the low 30s for the women over 60. It's in the high 20s. If we look at vaginal dryness, that's a little bit more common in women with tamoxifen and anastrozole at baseline. It's in the 30s. And if we look at joint pain, over 60% of the women just entering the trial had musculoskeletal complaints and joint pain. So this is very common in postmenopausal women. What I want to call your attention to is what happens at 6 months. And what we see in terms of the frequency of hot flashes, it goes up with both drugs in the younger and older women, a tad worse in the tamoxifen group. And if we look at vaginal dryness, that also goes up in both groups, but it's more significant in the vaginal dryness for anastrozole for vaginal dryness. And joint pain goes up about 10% for the women who were on tamoxifen and 20% for women who were on anastrozole. So in the next slides, I'm going to talk more about severity, which I think gives you a better picture of what women experience with both of these drugs. The questionnaire that we used rated the groups of symptoms on a score of 1 being slightly, 2 being moderate, 3 being quite a bit, and 4 being extremely. So the thing to note here is these scores are between 1 and 2 on average in terms of severity. So we're talking about modest severity of symptoms. Even though they may be frequent, they're not that severe. And on the left, if we look at vasomotor symptoms, the yellow curve is for tamoxifen, the aqua curve is for anastrozole, and what you see is that shortly after starting either one of these drugs, hot flashes, this was a composite of hot flashes and night sweats, go up in both groups, but nicely actually diminish over time in both groups. If you look on the right, the composite of musculoskeletal pains, which is joint pains, muscle aches, and general aches and pains, 3 items on that scale, we see that both of them go up, but much more significantly in the anastrozole treated group, and they do not really subside significantly. They stay up over time. If we look at sexual functioning, again, which had been one of our hypothesized scales, this is the MOS sexual functioning scale that has 4 items that look at various aspects of sexual functioning. Contrary to what we had hypothesized, there was no difference between the two groups. And just to give you a sense, a higher score means more sexual problems. A normal for someone who, the general population might be around 20, so this is an increase in sexual difficulties, but no difference between the two groups. Now, I want to talk about the stratified analysis because this gets back to the choice of how are we going to decide what drug is best for which group of people. We looked at women who were over 68 years of age, and those are the actual lower curves here, and the higher curves are for the women who were over age 60 for vasomotor symptoms. So not only are vasomotor symptoms worse in women treated with tamoxifen, but they're significantly greater in younger women. And again, we had hypothesized that anastrozole might be worse. We were wrong on this. Clearly, tamoxifen is worse. And so again, this might be a symptom that would be important to think about in younger women with tamoxifen. We also looked at the items on weight problems where we saw that younger women, again, no difference between the two groups on the right, between either of the two drugs, but younger women significantly reported greater difficulties with weight gain and being unhappy with their appearance. For vaginal symptoms, this is vaginal dryness and pain with intercourse, we see significantly greater problems for women. Again, not high severity. You know, we've got a severity up there around 1, but if you have it, it's a problem. And we see this, again, much more significant for younger women and worse with anastrozole. And on the right, very low symptomatology, but this is vaginal discharge and itching. Those are those items. And again, younger women having more difficulties. But again, low severity. It's close down near to 0. So, in conclusion, both anastrozole and tamoxifen are well tolerated in patients with DCIS with greater severity of some symptoms in women less than 60 years of age. The symptom profiles actually differ in the expected directions, and now, 13 years after we designed this trial, we know a lot more about these two drugs, and it's very consistent, but this is the patient report of the experience. And I think with this kind of information on patient-reported outcomes, as well as the breast cancer-free interval, which I showed you to begin with, which again, reminding you, no difference in breast cancer-free interval in women over 60, but a significant reduction in women less than 60, physicians and patients can now make much more personalized decisions about which of these two effective agents they should select. So thank you very much, and here are our acknowledgements. Again, patients, physicians, people all over North America who participated, our funders, and again, as noted by Dr. Cusick, this is appearing in the Lancet, the primary treatment trial results, the patient-reported outcome results, along with his trial. Thank you.
Thank you, Patty. Could you comment and put in context the weight gain? Because it may be misinformation to the public to say that both of these drugs cause weight gain, when the placebo-controlled trials earlier on showed that placebo also caused weight gain. So,
yeah. So this is, I think, you know, this is my particular area of interest, which is the interaction of menopause and breast cancer. And most women start to gain weight in their 50s just as their periods stop. And the questions, the items that we had on this self-report scale were having troubles with weight gain and being unhappy with one's appearance. In all of our other prevention trials, being unhappy with one's appearance was the highest rated item on all of our symptom scales. This is, you know, American women. I don't know what it is around the rest of the world. So that's a common problem. But I think when women stop having their periods and they start to gain weight, as a result of a lower metabolic rate and biologic circumstances. And then this drug is added, whichever drug it may be. It may be accelerated a bit by the anastrozole because you're taking a postmenopausal hormone level of 15 or 20, which is where you would be at in terms of estradiol, down to 0. And again, the drop in estrogen is associated with some weight gain. So we're talking about how women feel about themselves, and they felt worse if they were younger with either of these drugs. You know, again, it's not a difference between the two drugs, it's just where they are in their life.